So you're going to formally invite, or we just see like Indian culture is sometimes okay.
Do we speak from here?
Yes.
No,
And
no, we have to go.
Linda just went to the restroom, so we'll start after that.
Okay.
I'm here, right? Whoops, I'm here.
No, yeah, you are. Sorry.
This is Linda.
It does. I just checked it.
Thank you.
And I just put their last names at the beginning of each presentation.
Find those formal invites very formal. I find the formal invites very formal. You were asking, no, whether she'll invite us or should we just sit? I just prefer it like this.
It's like there's, I understand it's very. I am very informal person in my personal life, but
So that is why if we have to do some events, for me it's very difficult to do that opening,
Opening,
welcoming everyone,
exactly. So yes,
thanking everyone. I mean, you have to do it, so you do it. But
and also you need to spend time for this kind of formalities, and it's not. To me, it's not the best use of time always.
no,
but-
it's just that it
but
doesn't
still
come very
it's-
naturally. I have to put effort into doing that. So. But it's important. You've got to do it.
And there's Linda in
I
the
don't
list.
have a copy of my.
Do you need a copy?
Yeah, the one that I give you?
Yeah.
I'll remove the. But I'm usually used to having the laptop in front of me.
Yeah, it's to the right.
Okay. But I'll be sitting here and talking.
Yeah,
no?
that's fine. That's fine. Whatever you. We'll begin in one moment.
Turnout is moderate. So
You should all consider They usually do these like this type of thing here.
oh yeah, it seems that they are not used to this
Yeah.
all the equipment, and yeah, so that usually they are doing in center.
They're not used
Or,
to.
no, they are used to.
They're used to, yeah.
All this equipment, desktop, and they.
What's that colleague's name? Judy Moore. So
Judy.
just so that I remember to mention it to Karen.
Right, so why don't we go ahead and get started and begin today's event entitled South Asia Consultation on Maternal Health, Regional Dialogue and Way Forward. We are a small, intimate group today, so I would encourage you to come join us at the table. So when we do come to the discussion, we can all actively participate. My name is Sandeep Bathal, and I am the Senior Program Associate with the Maternal Health Initiative here at the Woodrow Wilson Center. And today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, where we explore challenges and discuss strategies for advancing maternal health. And our series is generously supported by the Maternal Health Task Force as well as UNFPA. As many of you know, the Wilson Center is a formal memorial to our 28th president, and we aim to bring the worlds of policy, practice, and academia together. For the second year in a row, we have been voted the top think tank to watch in the US and among the world's top 10 think tanks. So thank you for enabling us to have such rankings. Speaking of watching, I'm wanted to inform you all that we are being on webcast live today. So what that means when we come to the discussion is that I'd ask that you use a mic and introduce yourself, your name and affiliation. I also wanted to mention that we are using the Twitter handle #MHDialogue for anybody who wants to participate in that conversation as well. The Wi-Fi password is on the side. There you will see, and if you do join us for events regularly, I do want to point out that it's updated, and so you might need to reload your username if you're having any difficulties. I believe you all probably grabbed the bios from the front desks. So before I direct your attention now to our esteemed speakers, I wanted to give you just a little context to this meeting. For those of you who know me, you probably know that I am not a morning person. So one of the things that I do is lie in bed just a few minutes longer every morning by reading my work email. So I think it was sometime in mid-November that I received an email from Oxfam India inviting me to this consultation in Nepal. And needless to say, that is one day that I did not feel like I needed to hit the snooze button. I was really excited. I think my colleague Roger Mark, who operates a little different than I, had probably been up for like 4 hours at that point working, answered immediately because he was already online and said, wow, this is a great opportunity. So I was fortunate enough to be selected by Oxfam as one of the I was humbled to be recognized as one of the experts who could come together to talk about maternal health issues in the region. And I'm actually going to let Pallavi explain a little bit more why certain folks were invited to such a dialogue. But I do know from our perspective, I think it's our experience working in country on maternal health issues. So for those of you who do come to the events, you probably do know that we have partnered 4 times in total, but with 3 different international organizations abroad where we help them put together a full day discussion on maternal health issues. And the second day, we video conference what our findings are to an audience based here in DC. So we've done 2 meetings now with the African Population Health Research Center in Nairobi, 1 meeting with Population Foundation of India, and then just most recently in December with the Center for Population and Reproductive Health in Nigeria. So I know that we have some of the materials from those previous consultations, but it was that experience that helped and fed into our participation in Nepal. And so we mirrored some of what we did in those countries in the consultation there. I met with Balvi before and spoke to her as well as on the ground about how to do that. So what that entailed was full day presentations on what's going on in the region, and then we broke up into 4 separate working groups, which you'll hear more about, and had specific recommendations around topics such as how to address maternal morbidities in the region. So again, I don't want to take from the esteemed speakers who are going to talk about that in more detail. I am actually going to turn this over now to Dr. Linda Bartlett, who's an associate scientist at Johns Hopkins Bloomberg School of Public Health, who's going to start us off, kick us off. We're doing this a little differently than most of our typical events where you see a speaker go and then the next go. We're going to do a little back and forth because most of us were at this consultation together and we can build off of each other. So she's going to start us off right now talking a little bit about health stats in the region. So Linda.
Okay, hi everybody, and thank you so much for coming today. So as Sandeep said, I'm going to just start us off with a few minutes on the epidemiology in the region to set the context of essentially why we were meeting. So let's see if that works. Yes, it does. Okay, so these data are from the most recent UN WHO estimates published in 2014 from 2013 through 1990. And it shows that maternal mortality rates in the South Asian countries that were involved with this consultation, Bhutan is not on here because they weren't involved with the consultation, has declined substantially. So Sri Lanka is actually down at 29. Pakistan, Nepal, India, and Bangladesh all cluster around 170, 190, and Afghanistan is still higher than the others at 400. But these estimates show a substantial decline, and we're going to talk a little bit more about this in a minute. All of the countries are classified as making progress towards the MDGs, which is an annual decline between 2 to 5.5%, except for Nepal, which is actually on track for reaching the MDGs. So over 5.5% annual decline. And this slide shows the distribution of maternal causes of death, also from the most recent UN estimates. Published by Lalise in The Lancet last year. And so this shows that hemorrhage continues to be the leading cause in South Asia as it is globally. And it's followed closely by indirect causes, hypertension and sepsis are other important direct causes. But you'll see the group of other direct causes, the orange piece of the pie, which is 8%. Of maternal deaths in the region. And what I wanted to point out here, actually, if you don't mind if I ask you all a question, does anybody notice anything that's missing on here? There's some piece of information that, looking at maternal causes of death, that you would... Eclampsia would be under hypertension, but there's another cause. Obstructed labor, right? A couple of people said obstructed labor? Yes. So these new data are using the new classification of maternal deaths that WHO is a proponent of. I was actually involved with the working group, and unfortunately the end result was they excluded obstructed labor as a direct cause of maternal death. And I still don't personally agree with it, although people who I like and respect in the maternal health field do agree strongly with it, but I personally do not. And the reason is because when we did a maternal mortality study in Afghanistan in 2002, the leading cause of maternal deaths in Badakhshan was obstructed labor by far, more than hemorrhage. So the argument here is that they could present data in a bar chart showing that obstructed labor was a contributing event, like anemia or HIV could be a contributing issue. But the cause of death is then clouded within hemorrhage and infection. So, women who die of obstructed labor may die of hemorrhage or infection, or most likely die from that. But it doesn't guide the public health intervention, what's needed. And so, anyway, this is the newest data. So 3% out of the 8%, so almost half are obstructed labor and the other direct causes. And we're going to, again, come back to this in a minute. So the countries in South Asia are similar in that most of them have very large populations with very high levels of disparities. The majority of the populations are in rural areas with home births and unmet need for family planning. So as an example from Pakistan, our Pakistan colleagues presented these data where in 2009 the population was 180 million, with 65% rural, 4.4 to 5 million births per year. Nearly 60% of births continue to be home deliveries, of course, with huge disparities between urban and rural. Low levels of 4+ ANC, moderate levels of postnatal care, and 20% of married women having an unmet need. And so, despite declining MMRs, pregnancy-related causes of death still are a heavy burden among women of reproductive age. So this slide shows that pregnancy-related causes of death, out of all causes that would kill women of reproductive age in Pakistan, it is equivalent to infectious diseases, and those two causes dominate. So it's still a large burden in the country. And then I'm going to show some various examples of disparities from different countries, because we can't show all the data from each country, but to acknowledge the really important point of disparities. So this data is from Pakistan, the DHS done in 2011-12, and shows fertility by wealth quintiles. And you can see that the highest wealth quintile at 2.7 is about half, almost half, of what fertility is in the lowest quintile at 5.2. So about half. And this shows the maternal mortality ratio in the country. So overall it's 276, but it ranges from 227 in Punjab to 785 in Balochistan. That's really quite a difference, and that's more than twice as much. And actually, I heard fairly recently that the full tetanus vaccine prevalence in Balochistan among pregnant women is less than 10%, which to me was stunning. I haven't heard a stat that low, frankly. And as I talked with my Pakistan colleagues, we agreed that it seems horrifying that a country with nuclear capability can only vaccinate less than 10% of pregnant women in a whole big region of their country. Okay, so then this is maternal mortality in India, trends in maternal mortality from 1990 through 2013. And in Kerala, the MMR is as low as 61, and in Assam as high as 30. So again, big disparities. This shows facility deliveries by regions in Afghanistan. And if you combine the private and public sector parts of the bars, so that's the red and the blue together, then you can see, so central where Kabul is, it's over 60% of women deliver in a facility. But it goes down as low in the south where Kandahar is, and it's very insecure, to just over 10%. It's very low, so a lot of disparity. And even in Sri Lanka, which is sort of the star of the region with its MMR of 29 and incredible access, only 2.9% of the population live outside of 30 kilometers from a health facility. But of those women, their MMR is 70, the women who are outside a 30-kilometer buffer from a health facility, versus 35 for women who are within the 30 kilometers. So as I said, it's just a small proportion of the population, but there's still a substantial disparity even in Sri Lanka. Okay, and so again, looking at disparities with examples from countries, this comes from Bangladesh, and this shows the education effect on treatment seeking for maternal complications. And there has been improvement over the years. This shows data from the Bangladesh maternal mortality study in 2001 and then 2010. So in 2001, it was 6 times higher seeking treatment for complications among women with secondary education versus those with none. And this disparity has declined, but it's still very high, 3.1 times higher. And that's it for the background and context.
I mean, I'm certainly a visual learner, and the graphs were very powerful, but I think your quote there about your colleagues and you talking about vaccination in countries where that have nuclear capability was also very strong, and something I'll certainly take away from that presentation. So thank you, Linda.
Should we do questions now?
Does anybody need any clarifying information, or the rest we can, of course, save for the dialogue? Was there? I think there's a question back there.
I just wondered why abortion was still listed then as a direct cause, because that's also death caused by infection and embryo.
Exactly.
So why is the discrepancy between those?
That's one of our questions and arguments.
Can you actually
as
just
well.
repeat the question for the recording?
Oh,
Yeah.
sure. So the question is from a lady from ABT Associates, APT Associates, of why is abortion still a direct cause of maternal deaths when obstructed labor is not, when the most immediate cause of death from abortion would also be sepsis or hemorrhage, most likely, or embolism. And that was one of the discussions that we had and arguments, and it was just basically voted that way, whether not logical or not. Yeah.
Thank you. So we will come back to Linda. Linda is going to provide more insight into her experience in Kathmandu in a few minutes. We're now going to hear from Balvi Gupta, who's the program coordinator for health at Oxfam India, and one of our co-conspirators.
Hi, everyone, and thank you for joining us, and thanks to Sandeep for putting this together and having us here as the next step towards what we organize in Kathmandu. So to give a background of, as Sandeep said, why at Oxfam India we chose to bring that consultation together, I would like to take you through some of the work that we've been doing in India on maternal health, as a result of which we thought that a logical next step would be to bring experts from South Asian countries together. So just to take you through some of the work that we've been doing. Oxfam India has been implementing this work on maternal health for the last 3 years with support of DFID, the UK government. And as you perhaps know that in terms of absolute numbers, India has the highest maternal deaths happening in the world, though the maternal mortality ratio has reduced to 167, although we're still far away from achieving the MDG target. And personally, I'm not a very great fan of statistics, because I don't really trust that the statistics that we produce actually represent the reality on ground, because we've had instances of where maternal deaths have happened, but they were not on records of the government. So while you show a steep curve down, I personally would not really go by that. And that's why some of the discussions that we were having at the consultation and even after that is to focus also on the qualitative information for precisely this reason. But having said that, data is important, and this is what we have for now. And for every maternal death, there are anywhere between 20 to 100 women who will continue to live with a morbidity. And 20 to 100 is no range to give. No one in the logical senses should be giving such a huge range. But the reason is that there, as we will learn more when we go to the subgroup on maternal morbidity, there is no data collected on morbidity specifically that one can identify that what is the range and exact incidence of morbidity. And as Linda mentioned, in India, as in other South Asian countries, we have huge interstate and intrastate disparities. Even within a state, like the southern states which are otherwise advanced, you have pockets which are extremely backward and have extremely bad statistics. So the larger picture in a country like India, you look at one figure of national, is very different from when you break it down and go into specifics. So as a result, what we started in 2012 was a program on maternal health. So for some of you who may be familiar with the states in India, and this we covered about 5 lakh population in these 6 states of the country. And what we did here was to work on maternal health, but not from a clinical perspective, because we are not clinicians at Oxfam India. We are more from the point of view of public health practitioners. So improving maternal health with a social determinants approach. So while one idea was to link women in the villages with the public health services, the other was also to link and to improve the access to social determinants of maternal health, like nutrition, like education, like delayed marriage, and some of those. So which is why our approach consisted of cross-cutting social indicators, not only maternal health related indicators, of course they were a part of it, and community mobilization. So Oxfam India is a rights-based organization. We believe that the government is to provide services and people have to demand their services and get what is rightfully theirs from the government. So we essentially work on strengthening the public health system and increasing people's capacities to demand from the government and hold the government accountable. At the same time, also working in synergy with the government. So community mobilization was one of our main approaches. The other was strengthening the social sector programs. In India, we have programs for called the public distribution system, where food grains are provided at subsidized cost to certain communities. We have the integrated child development services, which provides early childhood education and nutritional supplements to pregnant and lactating women and to children. So we were looking at increasing people's access to these social sector programs, along with access to health services, which is part of the National Health Mission, which the Government of India brought in 2002. Then community-based monitoring and planning is a very important approach. It is, in a way, it is institutionalized in the country now, but when you go on ground, it's not really being implemented the way it has been envisaged. So for us, community-based monitoring and planning was a very, very important tool that we set out to get activated, working with the communities, getting them involved. I'll talk of that more a little later. Then training and involving community-based institutions. So community-based institutions consist of village health committees. And the expanded form is village health, sanitation, and nutrition committees. We started out with village health committees, and over the years, sanitation was added, then nutrition was added, precisely because recognizing the social determinants effect on health. So training and capacity building of some of these institutions, adolescent groups, working with the local governance. So all those strengthening such community-based institutions, and advocacy. Advocacy with the community, with other INGOs, with other NGOs, with the government, and I'll come to that part also in a while. So the process that we followed was, like I said, community level interventions. So involving awareness generation at the villages level, what is people's rights. We use different mechanisms for that, fairs, puppet shows, street plays, different kinds of activities at village level. Then activation and capacity building of what I was mentioning, village health, sanitation, nutrition committees. These are committees which have been mandated by the National Health Mission, by the Government of India. And each village, which is the smallest unit of habitation, is supposed to have this committee comprising of community members, local governance members, the health staff, the staff from the Integrated Child Development Services. So it's a committee where the community and the service providers come together. And this has been mandated, and so it is institutionalized. So working with these committees, and when we set out to work with them, we realized many people didn't know that they were part of these committees. So starting from there, and in some places we had to reconstitute them because the members had been, because of political pressure, some members had been appointed in it. So working through these committees by their capacity building, training one-on-one. Similarly, working with adolescent groups. And we have some success stories. There is some material outside. Maybe I see some of you have picked it up, where we have been able to document some of the success stories, and they are great, inspiring stories. For me, the success of these adolescent girls groups was the best outcome of the project. Engaging with the frontline workers. So like I said, that our approach is to work with the public health system, but it's also not about just blaming the health system. We also know that what conditions do these people work in? They're not the best of the conditions. They don't get the facilities that you and I get. So working with them, engaging with them constructively, positively, understanding their limitations and helping them overcome those limitations. And innovative activities, we used community members to form videos so that people, when they watch videos, they could relate to them. Use of community radio, then recipes from the locally available foods, the take-home ration, which is available as a nutritional supplement, which is often thrown. So how do women make it more palatable and tastier for them to eat? And we have experiences of women who've now started using that nutritional supplement, which is available from the government for free. Coming to the community-based monitoring and planning aspect of it, so working with the community, establishing, increasing their capacities, how do they monitor the health and nutrition services in their areas? What are the different aspects of it? So the community rates them in different, like you see the pinks and the greens and the yellows. The community rates what is the quality of services that they're getting at different levels. There is a Village Health and Nutrition Day, which is celebrated at each village once a month, where antenatal services, immunization, nutritional supplement is provided. Public health facilities. So what do people think of the facilities that they're getting at these various levels, based on which they prepare their own report cards for each facility. And after these report cards are prepared, they are shared with the system, with the service providers, that this is what the community thinks of the services that they're getting. These are the gaps that they find, and these gaps need to be resolved. And it also involves how the untied fund, this is something called the untied fund, which is available at each village. 10,000 Indian rupees, that's about how many dollars? 50? No. Yeah. So that they get annually. So how do they use that money? That's an untied fund, unrestricted. So they can use it the way they want to improve the health and nutrition and sanitation conditions in their villages. So regular dialogue between the two, and convergence meetings, so that the system doesn't see that the communities, if they're raising its voice, it's against us. It also sees the community as its allies and answers some of the community's questions and tries to address the gaps. As a result of which, I'm quickly running through this because Sandeep just gave me a warning of 5 minutes. Now I think it must be 3 minutes. The impact that we've seen is, we started to work out in 420 villages, and we recently had the national dissemination of this project, where one of our partners stood up and said, do you really think it's 420 villages? Are you sure? It's probably not 420, but more. Because what has happened is that in nearby villages, adjacent villages, also you've seen that people have seen what is happening in the neighboring village and have started picking up clues from there and working. So we've managed to activate these village level committees, which are now strong and are monitoring their own entitlements through these social sector programs. Some of these success stories are also documented in the material that is kept outside. Adolescent girls groups, they have managed to stop their marriages. the early marriages, which for me, like I was mentioning, is the best outcome of all the effort that we've put in. And this was together with the village health committee. So the community as a whole comes together and then they work on a particular issue. Defunct health sub-centers, the child nutrition centers, the Anganwadi centers which are called, they were made operational with the community's efforts. The primary health centers, the health facilities that are there at the village level, at the block level, their facilities have improved. This is not to say that Oxfam India has done it all of it alone. We have partners who work with this, and plus this is part of the Government of India schemes. But these schemes were not working. People were not getting them. So referral transport was not actually active. So we got the community to demand and get these going. Issues of corruption were caught by the community, like the use of untied fund. There's something called a maternity protection scheme. In that there was corruption and people found it and the money was given back to the community it belonged to. Regularization of supplies, the food ration that I was mentioning, which is given at subsidized costs. Increased uptake of nutritional supplements, temporary contraceptives, and improved services on the Village Health and Nutrition Day. And it's not only we who are saying it, even the service providers, because for us it's very important that the service providers see us as allies and don't see us as someone who's pointing fingers at them. So we have this doctor who's working in a very difficult area, and he's saying that as a result of the community-based monitoring, women have now come to know, and they ask and they demand. And as a result, we also come to know what is happening in the villages. So that also helps us plan our work better. Similarly, this is a nurse midwife who operates at the village level. And she's saying that she shared her problems with the villagers, and villagers helped her sort out some of those problems and made it easier for her to provide services. So this is where we see the two coming together. This is what the community has to say, that once we became a part of this, now I feel empowered, I know my rights. As a result of this, we came to know of issues and we started working on issues that impact our own lives. So these are the voices that we are hearing, and some of this, like I said, is documented in the stuff, in the material that is kept outside. Now this is what we did at the ground level in those 420 villages. Along with that, it's also important to build the bridge from ground to the top. Sandeep is looking at me, I'll finish in a minute. The advocacy initiatives that we undertook to link what we were doing on ground with the larger picture. We are in dialogue with the Ministry of Health and Family Welfare, National Human Rights Commission on taking some of the issues that have come up on ground together. Cross-learning initiative with development partners, this was a national consultation. Then we organized a maternal health in South Asia, moving beyond MMR, a Google Hangout. And you'll see moving beyond MMR in many places because, like I said, that numbers are important, but they only tell us so much. And because of the MDGs, the stress on numbers has been so much that some of the other aspects we feel have been left out. So that is why we are also focusing on moving beyond the maternal mortality ratio. Now comes why we all are here and how we all are here. We organized this South Asia consultation in Kathmandu in February. I'll come to that a little later. This is a picture of all of us having good fun together. And then as a result, as a next step of this, in February itself, there was a World Congress on Public Health, which this time was held in India, in Kolkata, where we put together a panel on South Asia, maternal health in South Asia, again, which was also a fallout of the South Asia consultation. Now, what happened in Kathmandu in February, we brought together maternal health experts from these 6 countries from which Linda presented some of the statistics also. And all the people whom we brought had been working on the issue of maternal health from a rights perspective, which for us is at the center of the work that we do, women and their rights. And it included scholars, practitioners, academicians, advocates, researchers from diverse fields, public health, medicine, medical anthropology, social enterprise. And the idea was to have people who worked in South Asia. So while we had people based in India, in Bangladesh, in Nepal, who belonged there, who worked there. From Afghanistan, we did not manage to get anyone who's locally based, but we had the good fortune of having Linda with us, who's worked extensively in Afghanistan. So while we had some people, most people from South Asian countries themselves, we had some people like Linda and Sandeep, and some others like Cecilia and Jan Brewston, who've worked in South Asian countries during their career and are experts in their own way in that region. So we brought all that group together so that South Asian people and people who lived outside but spent considerable time in those countries and know those countries very well could come together and exchange learnings. And so the idea was to sit together, take stock of what's happening in South Asia, and discuss how we could move forward. And it took us a lot of effort. The person who brought all of them together, my colleague, Anjali, she spent a lot of time figuring out who would be the right person for such a consultation, and that was, luckily we could get all of them together there. And like Sandeep said in the beginning, that first day we spent on country presentations, each country presenting about the status in their own country, the challenges, the achievements so far. And as we heard all the country presentations, all the experts realized that there were these four concerns which came up again and again in each country presentation. So they were kind of cutting across all countries, common to the region. In Sri Lanka, some things were slightly different, but in some ways, most of these were common to the other countries, and which is why we split into those 4 subgroups. So I think I'll stop here for now and move to others for the discussion that happened in the subgroups. Thank you.
Great, thank you. And Bobby, I was looking at you because you were talking. I passed you notes about the time when I need it to go faster. Does anybody have any clarifying questions for Bobby? No, but you can see, I'm sure, why I was so humbled to have been received that email, given the caliber of the folks that they brought together in the room. So we are actually now going to head back to hearing from Linda, and she's going to talk about 2 specific subgroups. She's going to talk about respectful reproductive health care as well as data needs. Thank you. Let me just put your PowerPoint back up.
Yeah, so while Sandeep is doing that, bringing up the slides, well, there they are already. But I just wanted to reiterate, because I think Pallavi is being modest on the part of Oxfam. It was really an incredible meeting. It was small enough that people could really talk and interact. It was, the vast majority were locals, people who were Indian or Nepalese, Pakistani, living and working in country. And the internationals who were involved were all of us had lived in one of the countries at some point and been very heavily engaged. And then the broadness of the expertise that they brought together was also very interesting. There were 2 medical anthropologists who has done a lot of research in Nepal and in India on women's perspectives about healthcare, in addition to obstetricians, midwives, researchers. So it was very rich, and we're hoping that this may possibly lead to other regional meetings in other parts of the world, like Sub-Saharan Africa, Southeast Asia.
And actually, if I could quickly interrupt to mention that we actually had 2 colleagues join us from Africa itself. I think it was Ghana and Zambia, to share their successes and also learn from some of the discussions as well. So just wanted to add that.
That's true. Okay, so I'm going to tell you about, there were 4 small groups. I'm going to present on 2 of them, and then Jahangir will present on 2. He and I actually happened to be in the same group, which was Human Resources for Health. So I'm presenting on 2 groups that I actually wasn't a part of, but the people who reported, Javeen Sharma from University of Edinburgh, who's Nepalese, and Cecilia Robinson, University of Syracuse, both spoke to me and gave me a lot of information in addition to the meeting notes on what they thought were the most important points in that came out of these groups. So any error is mine. So going on to the data first, while there is a lot of data collected, they felt that there was a lack of accurate and accessible data, and that this was an obstacle to understanding the situation in South Asia and an obstacle to planning as well. So I'm going back to this slide that I showed you at the beginning, which is the UN estimates for maternal mortality that were published in 2014. And what I'm going to show you here is the estimates also published in 2014 by IHME, Institute for Health Metrics and Evaluation in Seattle, led by Chris Murray. And they've been given a large grant by the Gates Foundation a number of years ago to also work on data collection and strengthening. And so they've also come out with maternal mortality estimates, I think, in about the past 5 years, maybe 6 or so. And so this shows in South Asia how the estimates differ. And so this is not a criticism of either of the methods, but to show that it's really hard to know what's going on. So the South Asian overall estimate from IHME is 311, the MMR is 311, whereas the UN is 190. So that's a lot lower. And a lot of that is driven by the MMR that they estimate for Afghanistan in 2013 was still 885, whereas UN estimated it at 400. And Pakistan was also quite a bit higher at 401. So I'm showing you this as an example of, leaders, ministers of health will look at what's our country estimate in addition to their own data that they have from DHS or other national surveys, and it can be confusing. So, and then I showed you the UN causes of death distribution for 2013 published in 2014 as well, and what I'm showing on the right is the same data from IHME. And in their data, you can see that hemorrhage is less of a contributor at 19% than the UN at 31%, and part of the reason would be that they include obstructed labor as a direct cause still. So again, it's not meant to be a criticism, it's just an acknowledgement of the diversity and disparity within data and how even at the international level it starts to be confusing and clouding in some ways. Also, I think it's really important to have different estimates rather than just one source. Okay, so these were the things that they've talked about. So issues with data availability and quality, that there was basically insufficient or no verification processes at the point of data generation, whether it's a CHW or a midwife, or if it's a data collector in a special survey. There's little or no access to raw data. Basically, usually only processed data is available to the public. There's inadequate reporting of maternal deaths, very little data on maternal morbidities, and only periodic special studies on perceptions of clients. And here's a quote from the report that there's pressure to deliver and show better results, and there was a concern by the group that in the absence of proper supervision and monitoring, there's concern that result-based frameworks have led to a pressure to report better results. And in addition, as mentioned, there is a large amount of data being collected and generated in countries, but it is almost always quantitative and generated on predetermined categories by the government and or whoever is collecting the data or doing the survey. And often user experiences are left out, basically qualitative data. And data equity as a concept of the need for disaggregated data was an issue, that being able to disaggregate the data by religion, caste, ethnicity, rural, urban, income, education is really important to assist with planning. So the purpose of data collection ought to go beyond collection for reporting to higher authorities. So first of all, data collected is not often analyzed at a local level, district, or even village, or presented back to them. In addition, people are asked to collect data who maybe are not really trained as to the purpose. They could be trained in, you check off, this checkbox, this column, this kind of thing, but what's the purpose? How is this informing you? How is this informing us? So we think that better education in that could be helpful. As I'd mentioned, little systematic qualitative data is being collected to inform on user and provider experiences. And also there was discussion about how NGOs and funders have their own data collection, which could offer very rich information on development worker experiences and other indicators that we're not collecting at a government sort of Ministry of Health, health management information system. And that was an untapped source of data. So going on to the recommendations, sorry. There was a recommendation, first off, for a more robust data collection process that includes verification both at routine and non-routine, i.e. special study is required. An example was the frontline health workers who I just mentioned, and education on what the data would be used for, and then also feeding them back the data. What does this mean? What are the numbers that you've just provided, say, on interventions that a woman has received at a basic health center level to what we know about the district and what's needed in the district? And to do this, strengthening supportive supervision and monitoring is needed, and we need the resources to do that. So overall, additional funding is needed in data. The second set of recommendation was to encourage data usage at all levels. We've talked about that, that it should be available for district or village level, whatever is of interest, and it should be accessible. So Pallavi and I were talking this morning with the group, and she gave an example where to access the data on the HMIS, you have to be registered, so you have to be sort of at a status of being able to get registered and have a username and a login. So it's just not accessible to the general public. Ensure that the vulnerable populations have data collected by gender, ethnicity, caste, et cetera, so that that data can be disaggregated and looked at. And we've talked about the other things. So there was a very interesting point and discussion about utilizing the data generated by NGOs and funders, and Dr. Sharma talked about a shadow report, and I personally wasn't familiar with that term before. Maybe you all are, but just to somewhat define it, it's a report that has been used in human rights examinations in particular, where information from NGOs and other organizations or people in country is collated and offered to whoever is examining the keeping with the human rights treaties, et cetera, in addition to the official ones. So they're called a shadow report. But it could be called informal. But having worked with UNICEF in Afghanistan, I thought that was a really good idea, because we had data that just wasn't collected nationally and wasn't really made available nationally. So the reports would be distributed, but they weren't ever collated with other groups. I thought that was a very interesting and good idea. So a landscape analysis or shadow report on an annual basis would be something that could be considered. And to improve the data collected to audit the processes and the usage. And then last, to consider beginning to limit the number of surveys as time goes on and capacity can be built, surveys by external groups, and trying to bring it more in country. And then with external technical assistance as needed, but focusing again on capacity building in country. And also to have less reliance on periodic surveys and studies, which can be very expensive, and start to build capacity for sample registration systems and vital registration. And then also developing capacity for routine qualitative data collection. So I'm getting the look from Sandy.
I was looking down that time. I know that you haven't had a chance to talk about respectful reproductive health care yet, so I think that it's okay if you spend some time on that.
Okay, I'll try and go kind of quickly. Okay, so the Respectful Maternity Care Group, the report was given by Cecilia Robinson, who's in this picture here. A shout out to Cecilia, University of Syracuse, and she was very helpful to me last week and this week as I prepared for this. So they adopted the WHO definition, which I haven't written out in full, but the key points are providing dignity to the patient, true informed consent, open communication, and providing all the options and choices were some of the key points within the definition. So the problem statement was that there are instances of obstetric violence, violation of patients' rights by physicians and other health personnel, disrespect and abuse in the labor room, and corruption are not uncommon in South Asian and other developing countries around the world. This is just, it's a new topic I'm sure you're all familiar with. It's kind of come up in the past few years as part of the issues of quality of care, and which I think is a really important thing to be looking at now and addressing. So a quote from the group, "Safe motherhood should go beyond mortality and morbidity to include respect for women's basic human rights, which includes dignity, feelings, choices, and preferences, including companionship during maternity care." There was discussion of the intersection between structural factors termed structural violence, where things like gender, patriarchal societies, caste, religion, etc., ethnicity are structures that can cause harm through a systematic discrimination, and that can be very complex to understand, acknowledge, and address. But it was talked about at this meeting, and people felt that examination of this needs to start occurring. So accountability for respect for the woman and respectful, kind care needs to be part of the health system, and the accountability needs to be part of the health system. But also there was recognition, which I was also happy to see, that constraints among the health workers is a big component of this. Lack of time, not enough money, busyness, lack of resources lead to frustration and stress. Not that it excuses it, but also I think we need to acknowledge this is not just a group of nasty people doing this. There are really serious stresses that contribute to this serious problem. So the recommendations from this group included an urgent need to include education for this at all levels of the health system, including auxiliary workers, like even cleaners. And when we were talking about this in Nepal, I gave them an example that in Afghanistan in 2002, it was actually the cleaner who did the triage at the front door of one of the maternity hospitals. So she would hold the front door closed and allow people in as she saw fit. And so, and the doctors and nurses and midwives said, well, we fired her and told her to go away, and she just comes back the next day. So including all levels of anybody working in the facility needs to be done, or community health workers as well in the community. And this should be pre-service and in-service. So an example was a 2-day workshop in Pakistan that was being done by invitation in medical schools and midwifery training programs, and was being quite well taken up and accepted. And a point that was made was it would be important that the training has a competence of learning to negotiate rather than to enforce. So in some contexts, some things are not appropriate. An example would be a husband being encouraged to come in the labor and delivery room, and him and his wife preferring not to. So then another recommendation was making provision of respectful care and accountability to that part of an accreditation process of health centers. And so promoting mother-friendly health facilities, sort of analogous to baby-friendly facilities, was an idea that came up that I thought was very interesting. So this would be a set of goals that facilities would try to attain, and certain ones would be required for accreditation. They felt that doctors need to take the lead in accountability because they are often role models, and that there should be champions and that whole system of advocacy. And discussion of bringing this into the advocacy realm, into the broader activist agenda opposing violence against women in general, using media and celebrities, involving and activating the community. Accountability, we talked about. Some methods would be, to examine them, would be exit surveys, or apparently in some studies there have been undercover patients who have gone into a facility to report then anonymously on the care received. And discussion about the AIDS, the very successful AIDS activist strategies that occurred to bring attention to that problem were discussed as a model for this problem. So then, last slide, the priority next steps from both the small groups. So there was all these recommendations, all these points and concepts, and then each group had to tell Pallavi, out of all our things that we've said, these are our 1, 2, or 3 things that we think need to be worked on as priorities for the immediate next steps. So for data, this included disaggregated data so that we can understand and document disparities and plan for them, promoting use for data at a local level, and that raw data should be easily accessible. And for the Respectful Maternity Care Group, it was a protocol for conduct of providers with clear guidelines for actions in case of violations. So these are available in facilities, people have been trained on them, and they're aware of them. Education and guidance should be part of pre-service and in-service education, and involving the community, helping them to generate demand. Thank you.
Thank you. I just actually wanted to go back to one of your points and about using celebrities and the media. And just to put this in a South Asian context, that's huge. I can guarantee if any sort of, Bollywood, if that went without saying there, but, if any celebrity was to take on this task, I can promise you that my mother would know about it because, the way the diaspora works, in a lot of cases that, my parents don't have an American TV. It's like, hundreds, I think, of, at this point, channels coming in from India. So I think I just wanted to put that perspective out there for those of you who might not be familiar with the region. I think using celebrities in particular around social issues is quite significant across the world, of course. But then, you see, I know I've been in Indonesia and like people are yelling like actresses' names behind us. I mean, these are movies that are seen across the world, and so I think that there's just a lot of significance in that. So I wanted to add to that. I'm also sorry. You can have a seat. I'm just babbling.
I was just wondering if
yeah, and clarifying questions, of course. But go ahead. Oh, we need a mic, sorry, just so the folks tuning in can hear you. So if you could just give my colleague 1 minute to get to you.
It's actually a very basic question. So I'm Vinita from ACOG, American College of Obstetricians and Gynecologists. And I wanted to know a little bit more if you could clarify between 2 groups that you mentioned, NGO and funders, like data collected from. A little bit more, like what do you mean when you mention them as a separate group?
Okay, so the types of data collected.
No, what are those groups, like NGOs and funders? Like, do you see them as like a Gates Foundation as funders?
Yeah, so Gates Foundation, USAID, World Bank, they have to show back to their agency that the money that they're spending is having some impact. So the people who they fund will collect data, like, say, for example, the number of bed nets distributed for malaria prevention among pregnant women, and even malaria rates among pregnant women in the areas where the bed nets were distributed. So they will ask for data like that to be collected and provided to them. And so that kind of is an example that would encompass an NGO. If they fund UNICEF to do that, that's what UNICEF will collect and then provide to a funder.
And the only one last point, and it's not just babble, I hope, that I wanted to make is for those of you who are familiar with our sessions, we always record them, and you can always find the archived events on our website. And we have had specific events. I'm sure most of you know that one of our funders in particular, the Maternal Health Task Force, is really interested in doing a lot of work around respectful care. So we hosted a panel sometime last year on that. So if you are interested in that topic in particular, that's another thing you can tap into. I know our internal timeline, we are a bit behind, but I did not want to I did not want to take from this, because, I mean, as we've heard from Balvi as well as Linda, I mean, I think that these were a group of people getting together and really coming up with some innovative ideas, and I didn't want to short us from hearing about that second group. So now Dr. Jahangir Hussain is going to speak to us. He's a program director of health at CARE Bangladesh, and he's going to talk to us a little bit about the remaining two groups and the recommendations that came from that. So Jahangir, thank you.
Good afternoon, and first I want to thank Wilson Center and Sandeep for organizing this session and give me the opportunity. What I am going to reflect basically two kind of outcome of two working group. One is human resource for maternal health and maternal morbidity. However, since I came from an organization and working for CARE and based in Asia and Bangladesh, so I try to bring one kind of solution as well, so that some is because the human resource for health is one of the critical issue, and that we tested some innovation, and just I will take the chance to share some of this experience. So that's my the outline. And first, if you want to reflect the human resource working group recommendation, actually there is a very diverse group. So it's from public health, professional, clinician, journalist, women activist, so that when we discuss the issue, and different people have the different perspective, and which is very good and useful, so that to discuss and come to a consensus. And when we are discussing about this human resource for maternal health, and the group took into consideration the whole complexity of each of the country, and current situation versus desired situation that every country want to go, and also like whole continuum from community up to the tertiary facility, so different level of community level, even formal and informal provider, and how to recognize even informal provider, and kind of there's some kind of inherent skill which is psychological and social. So that's kind of the debate and discussion are there, and I am going to just discuss some kind of specific recommendation. Like one of the recommendation is, yes, a state should have the responsibility to provide skill maternal health provider at each level, from community up to tertiary facility, with equipped and supported, and they receive regular supply and drugs. And there are some discussion about the midwives, so that all the basic UC facility should be led by midwives, and will be very well kind of connected with the tertiary or comprehensive UC facility as well as the community. And another discussion was a recommendation around this. When we will be planning for human resource, women should be center in our kind of planning. Like sometimes, often we provide training to the human resource for maternal health on technical issues. But what about the social issues, like respectful care, gender, like accountability, human rights? So that need to be considered, as well as there is a discussion that women should be just kind of zero tolerance to any kind of abuse and misbehavior when women in labor. So that should be practiced everywhere. There's the norms. That kind of discussion we had in our group. And then, and as because the different country using kind of, though there is some international standard and country adopted it, and then just country and any kind of training school, they should accredited by nationally kind of accepted guideline, which is in line with the international standard. And that was the kind of and as well as the whole issue of human resource for health management information system should be there should be an updated system, and there should be disclosure to the public, so that to bring the accountability. So public representatives should know the whole deficiency and gap, and they can talk about it. And discussion, and there is a huge discussion and the recommendation around this, how to use this existing for informal community health workers, like TVS. And they have some, and there is a discussion, okay, they cannot be the delivery provider, but their psychological and social skill can be used to support the woman when they come. And there are some evidence like use them like for like essential newborn care and managing like sepsis and detection of some like maternal sepsis and newborn sepsis, and then refer on time. So if anyone want to just use this kind of informal provider, that should be based on the international and evidence, should be supported by evidence. And also there is a discussion about the whole security issue about this, because there are some remote area where the midwives they are living, and what is about their security issue? State should take their responsibility, as well as some kind of rewarding and some special payment for them to just retain them, to attract them, so that they are retained in kind of remote areas, because that's the big issue in most of the developing country. So that was just on this human resource part and the maternal morbidity. And the first thing, there was a discussion, there is no even recognition about the maternal morbidity, as because everybody is so inclined and about maternal mortality. And just no, there is no country in South Asia except Sri Lanka who track the maternal morbidity data. So that was the discussion, and then the emphasis should be there. And then the recommendation is there should be a kind of data collection and evidence, and using and incorporate within the existing human management information system, and also share this evidence with the policymakers, so that to mobilize their commitment and support to address those issues. And also like whole training about these midwives and nurses, those who are maternal health provider, about this morbidity issue, how to prevent and treat and detect. So, and involvement of the gynecological and other society and the professional bodies of the East country. And one important thing that discussed, and like social determinant that impact on maternal morbidity, especially early marriage and low literacy, delay in seeking care. So these are the big issues that need to under consideration and have kind of some intervention in addition to the direct intervention, and the general awareness among the people about this morbidity and how to refer. And it was discussed, it goes with this, the access to skilled birth attendant is one of the important things just to prevent the morbidity. Now I'm going to just quickly reflect, okay, human resource, shortage of human resource is a big issue. Like it's one of the examples just that we have been implementing in Bangladesh, human resource shortage in remote area through a kind of innovative public-private partnership. GlaxoSmithKline supporting us, and we are partnering with Ministry of Health, and it is known as a kind of more public-private partnership, as because the Ministry of Health is partnering with a new private cadre that CARE is trying to develop. And just to give a kind of, Sunamganj is one of the remote districts like this in Bangladesh. And if you see the, like we saw the data, like maybe 190 is maternal mortality rate per 100,000 is live birth, but in Sunamganj it's almost double. And most of all the health indicator is almost double than the national. And it's a flood-prone area. It's experienced regular interval flood, and health system is not really working in this remote area, as because usually the poor people are living there. The well-off people, they are not living there. So there is a shortage, vacancy of the position, retention is a big issue. and whole health system is not functioning. And then unskilled provider, and they are kind of filling the gap. And in any way, these people, they are spending money. 67% is out-of-pocket expenditure. Still, they're spending money from there. And then the whole purpose of the project is to ensure consistent, high-quality, and sustainable maternal and child health services for 1.4 million people. And we covered 10 sub-districts and 50 union, which is the smallest local administrative unit. And we established 168 skill community-based private provider. It's maternal and child health provider. And just I am going to, and they cover more than 7,000 population. And they are kind of selected by the community and the local government and the Ministry of Health people at the sub-district level, and using some certain criteria, which is Nursing Council and the government Ministry of Health accredited and identified criteria. And they have gone through 6-month training, which is, the training is being accredited by WHO and Ministry of Health, and 3-month kind of field-based training. And they also receive some other training on primary health care and just community integrated management of childhood illness, family planning, and like some training on health MIS. And also, especially just they receive training in entrepreneurship, like how to, as because there's a private provider, how they can analyze their own market size, develop their own business plan, and how to like who are the kind of other competitor, so that she can really penetrate in the market and sell her product and services. So that's kind of training, so that it's coming from the private and linked with the commodity and commodity suppliers and drug sellers, as well as collaborate with the TBS, traditional birth attendants, so that there is no unhealthy competition with them. And the backbone of this approach is each of the private MCS provider are supported by a community support group, and which is led by a local government representative, the elites, school teacher, women, so it's like mixed group, adolescents, and they have some particulars. They said initially what they did, they helped them in identifying them, and when they came back after the training, they introduced them with the community, and also they negotiate the price rate, how much for ANC, PNC, and the delivery, and so that this community helped them to negotiate the price. So there is a transparency. And also like there is a negotiation, if the poorest of the poor, she is going to serve, she can reimburse from the Ministry of Health, it's called demand side financing scheme, or from the local government, so that she's, in any way she's paying. And this local group, they are mobilizing some local resources for transportation of the woman in case of any kind of emergency, and they're tracking each of the pregnancy and refer to them. And if we see the results, after 13 months, and we find that almost all pregnancy in the catchment area is identified and registered, and 99% receive at least first ANC by this skilled MNCS provider. And if we see the data, and sometimes when we are talking about private provider, and then there is a question whether the poor and extreme poor, they will be out of service. And no, it's like 68% service recipient are either poor and ultra poor. Even if there is a quality service, it's available at the doorstep, people are paying for it. So that's the kind of experience. If you see the in the baseline, which was done by ICDDRB, the 12% was the skill attendance at birth, and which is now after 1 year, so 49%. And contribution of this new cadre is 34%, is increased. By the government, it's 12 to 15. Same, if you see the ANC services and PNC services, and after 1 year, it's increased by 55% and 33%. And that's the attribution of this new cadre. So it's like, because there is a good local MIS system, and they share regularly with the government. And if you see this service contract, especially for maternal health service contract, that increase over time. Is average 67, the number of contact per month. And also their earning also increasing, which is $33 per month. If you see in December we see the 33% of this provider, they're earning $40, and 15% of them, it's more than $67. And $67 they see as a kind of benchmark that can sustain their service and the commitment, as because that's for that kind of remote locality, that's fine for them. So saying that we can just conclude that a skill, as because we don't want to just only rely on the government and public health system, as because in any way the private sector they're growing like mushroom, and they have their own way to just replace if the public system is not functioning. And it's good to support the private sector in a way, so that's why government is also, Ministry of Health of Bangladesh, they're also excited to support and part of this. And we see that, and they also recognize that this provider can complement government service in remote area where public system is not adequately functioning. Maybe that will, and also that reduce reliance on unskilled and traditional providers, as because they are being exploited by them, and potentially sustainable. And we need to further and reduce both challenges, wealth and geographical inequality in accessing maternity services. So, and we find that, and this is the picture of this new cadre, so that I try to share with you, okay, there's some problem, and yeah, there are some solution, and government is not alone responsible to do that, as because private sector also growing, and we need to help them to take the place, and they are more accountable and work along with government. Thank you.
Thank you. Any clarifying questions before Jahangir sits down? Great, thank you. Oh, sorry, it looks like there is one on the side. 1 second, can you wait for the mic?
Yeah.
It's right behind you. Yeah, I don't know that it's on. 1 second. It's for the recording. I know we can hear each other, but they can't hear us. They can only hear me right now.
Thank you so much, Jahangir. It's a great presentation. So when you mention private in this instance, what does that mean? Like you were talking about the earnings earlier. I wasn't quite sure what that was referring to.
Just when we are talking about the private, this cadre was not exist before there. So we identified them from the community, like grade 10 or 12, and who are interested to develop this new skill and serve to the community. And so they are totally independent, and so that's why they are private. So they are not part of the government kind of organogram, but they are linked with the government, and government recognize them. And like, for example, government community, like family planning, ORS, and they're distributing that. And since government system is not working, government use them as a kind of extension worker. And government also supervise them for their quality of care. Bi-monthly, government organized the refresher training at the sub-district level. So that's why we call the public-private partnership, and the private is this individual provider. She is totally private. Okay.
Thank you. Is this a clarifying question? Okay.
Very quickly, were they volunteered or were they paid a stipend?
For initial 2 years, they received a stipend per month, $30. So just to sit and just start her work, and so and they know it, and that was discussed and shared when they are selected for this. Yeah.
Great, thank you. So, one of the things that I should have mentioned earlier is that, up until this point, you've heard from folks that were in Nepal for this consultation, and I appreciated having a more specific example around midwives in the area, especially since we spent so much time talking about them, especially when we were thinking about HR. I know in just a few minutes, we're going to hear from Barbara Stillwell, who's the Senior Director of Health Workforce Solutions for Intra Health International, and she's going to give us some of her perspectives on what we talked about and how it sounds for someone who wasn't there. In particular, Barbara, when we get to your portion, I was hoping that you can maybe share some insights on perhaps the training and monitoring of midwives, and then also, as Jahangir talked about the various points, how the postpartum period relates to morbidities in particular. But before we hear from you, Bolvi is going to quickly wrap up and talk about what the next steps are after such a consultation. And she has a quick video that I meant to show a little earlier, for about 4 minutes, on the consultation itself. So I can bring that up if it's easier.
Home to more than 1/5 of the world's population, South Asia is a paradoxical land of tradition and modernity. Even with the unprecedented advancements in health and medicine, women still face a high risk of death and morbidity in the most natural phenomenon of human existence, childbirth. Most governments and international development agencies working in South Asia adopted the Millennium Development Goals, or MDGs, as a framework for action to improve maternal health. MDGs have no doubt provided the necessary impetus towards reducing maternal mortality ratio, or MMR. However, despite decreased MMR during the last decade, the maternal health crisis is far from over in South Asia. Maternal mortality in the region is currently only second in the world. When measured against the MDGs, the progress has not been satisfactory in Afghanistan, Pakistan, and India. Bangladesh has achieved many MDGs and has shown remarkable progress on MDG 5, and Sri Lanka has an exemplary record in maternal health. Nepal has shown extraordinary improvement and has been able to achieve MDG 5. Even though there have been some breakthroughs, certain issues continue to linger. Oxfam India organized the South Asia Consultation on Maternal Health, a regional dialogue and a way forward, at Kathmandu in Nepal on the February 4th and 5th of 2015, with support from DFID Global Poverty Action Fund. The consultation was a part of Oxfam India's ongoing commitment to ensuring access to quality healthcare to women and children by strengthening the public health system and engagement of communities in their health. The consultation was a 2-day event bringing together scholars, practitioners and experts from the field of public health, medicine and social enterprises, with the objective of stock-taking the maternal health scenario in South Asia and discussing future strategies.
Who's a trained birth attendant?
The South Asian teams were also given an insight of learnings from Ghana and Zambia in Africa.
Also learn from what our friends are doing in Africa, especially in Ghana and Zambia.
The platform fostered discussions on strategies to take forward the maternal health agenda beyond the MDGs and the Sustainable Development Goals 2030. Each expert delegate represented their countries and detailed the current programs, shared ideas and innovations, identified cross-sectoral synergies and best practices.
Another good thing Bangladesh did, because from the very beginning, the government and NGO sector employed female health workers. So female health workers' involvement raised the way of doing the community mobilization.
The event helped in identifying common challenges and opportunities for cross-learning between different South Asian countries.
Community-based organizations have always played a very important role. So now they can be partners in empowering the community much more than before in terms of getting information. So you can have health information and health education programs with partnerships with communities. Then also alerting communities of emerging health issues so that they can be prepared.
Any underdeveloped country who want to save their women, they should invest in midwifery. And when these skilled competent midwives are available in the villages, in the hospitals, they will save 90% of the women.
It was agreed by participants that meetings such as this cross-learning initiative are a welcome step and foster dialogues and collaborations between various organizations. We hope that this consultation would help in taking forward the maternal health agenda in South Asia further.
That was a
Home
glimpse
to more
of...
than 1/5 of the
Oh,
world's
sorry.
population, South Asia is a paradoxical land of tradition and
So that was a glimpse of what we did for 2 days, and this is not final. So I've been telling Sandeep, don't let it be out by itself as a video on its standalone, because you saw there weren't names of people who were talking, so the credits are not there. So it's not yet final, but that was just to give a feel of what it was like when we all got together. Just to wrap up the discussion on that particular consultation, that how, as Oxfam India, now we see the process going forward and not ending at that particular consultation. So there was a talk of forming a South Asia working group on maternal health, which I see is already getting formed by such coming together, such consultations. So we are forming an e-group of the participants who were there. And also there was a discussion of having such meetings face-to-face every now and then. Of course, funding would be needed, but then we thought that if all of us got together, we could probably come together once in a year or once in 2 years. So form a South Asia group. And for the e-group, it was decided that every alternate month, the group meets for half an hour and picks up one particular issue and discusses. So the first of that will happen in April now. And networking and collaborating to take the advocacy agenda further. This again has already started, like I mentioned about the World Congress on Public Health, where some of us got together. This is another one where Sandeep has brought us together. So such collaborations and taking learnings from one place to the other and collaborating with each other. The shadow report that Linda mentioned about the status of maternal health in South Asia, including both quantitative and qualitative data. So this is still to take more shape, but we are working on it. And as and when it comes out, we'll also focus a lot on the qualitative data as we've been talking here. Then sharing communication and advocacy material that we all generate in our countries, how it can be used in other places. And one more, which was exciting at that time, and I hope it is possible, but of course funding will be a constraint, but exposure visits to learn best practices. Like some of us are very enthused to see the Sri Lanka experience, so why not go and learn there? Some things in Bangladesh were very nice that we wanted to see. In Pakistan, there were some great examples. So some of that kind, if it is possible. So while at Oxfam India, we did not promise and cannot promise at this stage that we will continue to doing this, but all of us together will definitely endeavor that we continue this relationship and this dialogue. So with that, I think we'll wrap up the discussion on South Asia consultation and move to the next.
So, Barbara, you're going to tell us how we did when it comes to workplace development.
Okay.
Thank you so much. I'm very honoured and somewhat humbled to be asked to comment on this amazing consultation. And I've been asked to look at it from a health workforce perspective. What I want to start by saying is that I think South Asia has made remarkable progress in maternal health outcomes and in the way that the workforce, the health workforce, has really responded to what's needed and what's been needed. I think it's been very creative, and I'll show you in a moment how I think they've done that. IntraHealth has been involved in really compared to you guys in a smaller way in India, though we had a large project there where we have looked at some initiatives on maternal health, which I might well refer to. So we have a little bit of experience, not as much as you guys have, and much kudos to all of you for what you've done and for this meeting, which sounds amazing. So what I took away, I've become very familiar with the meeting because I've read the report many times, and what I took away from it is that there are too few midwives stroke skilled birth attendants. So that's about availability of the health workforce. that they're not well deployed, that's about accessibility, and that the quality of care is not yet right everywhere. So that's about acceptability, respectful care, and the quality of care. So what are availability, accessibility, acceptability, and quality, dear audience? Where are those to be seen and found together? Yes, universal health care, the right to health, AAAQ. Okay, so I wanted to relate that to what you've done because going forward, you know, we've talked about the MDGs, but as from this year, we're in another world. We're in a world of SDGs, sustainability, resilience, availability, accessibility, acceptability, and quality for everybody. So this is a brave new world, 2015 to 2030. So one of the other documents that I reviewed very closely, because I knew I was coming here, was the State of Midwifery 2014. Fabulous reading. If you haven't read it, it's great. And one of the connections I have with that is that Jim Campbell, who was one of the editors and writers of that report, is now the executive director of the Global Health Workforce Alliance. And I'm working with him now on some reports of numbers of human resources. So I've kind of got very familiar with his approach on much of this. And basically, really, his approach is much the same as the rest of us has been for the last 15 years. I started working on international HR in the year 2000. So what we do as a sort of global HR community is we look at the pipeline of the health workforce. So we look at entrance to exit. Or as I once heard you say in your world, sperm to worm, but we don't quite go back that far. So, but we do go to the worm part of it. So if you look here at intervention points, at entrance, what often happens in low and middle income countries is you have very few people going to secondary school and qualifying, you know, at advanced level, particularly women. And I understand that that is the case in Asia often as well, that women don't have the same access to higher education. So people going in to be doctors, midwives, university teachers, tend to be smaller in number, unless you create a way to bridge that. And we've heard about that in some of these skilled birth attendants, 6 months, 9 months training, which is fine because that brings in some of the population that wouldn't otherwise get in. And they can enter into an institute. One of the things that happens sometimes then that we tend to look at is whether there's attrition from education. And that can be, you know, that can really take a lot of folks out of education if they can't afford to pay. Do they go into the pool of qualified workers or do they migrate? And I know in India there's a big migrant population because they come here and they go, thank you to England, and they go backwards and forwards a lot. So that's another issue of concern. And then obviously the next thing is, can they be employed in the health sector or not? You know, what's the labour market look like? How often do we look at that? Do we then prepare lots more health workers who don't become health workers? They go into something else or they migrate. And then, sorry, 1 star missing. Then, you know, how long do they stay in the health workforce? Is there attrition from the health workforce? Will they go to a rural area? Will they not go to a rural area? How will we encourage them to go? So, this is the area in which we in international human resources work with some success. But what tends to happen is that this picture, all that's in this picture has to be, as it were, governed by the Ministry of Health. They have to be looking at all of these interventions and how they flow one into the other. And to bring in a point that Jangir raised, I think, what's the private sector doing in this? Are they recruiting people from the public schools into the private sector? How is that interacting? So It's a real big picture thing. And what we found is that while these interventions work, and there are lots of tools that you can use for each of these starred intervention points, and will give you information and and you've heard about some of the interventions that are being designed based on some of these issues, which work. They do work. However, there is now some idea in my world of global HRH that we need to be coming up with big ideas that are going to change the way we look at these issues in a way which is much more profound than this. This is a very mechanical model. Nothing wrong with that. It works. But there are some more profound things which I believe are more to do with respectful care than looking at a mechanical model like this. So I'm going to share with you one big idea, to be a little bit provocative. So this is our look for new solutions, and it's very much based, this big idea is based on Dan Pink, who wrote a book called Drive. And what he said was, in Drive, and I shared a platform with Dan Pink at a conference, and so that's how I know quite a lot about his work and have managed to apply it to some of our work. So what he said was, what we do is, to give people incentives, we offer them a pound of carrots. And when a pound of carrots doesn't work, we offer them 2 pounds of carrots. And then we're very surprised when that doesn't work. And he's right, you know. We offer financial incentives. They work for a while, but then they stop working to put people into rural areas because the cost of living rises, cost of housing rises, and it's not the only problem. So he suggests looking for what he calls job enrichment, autonomy, mastery, and purpose. And these are the 3 elements of job enrichment. So very quickly, autonomy is about self-direction. It's about, remember Maslow's hierarchy of needs and self-actualization and how that comes at the top and how we never take any notice of it, hardly ever at all. We talk about food and, you know, we talk about work and all those things, but self-actualization is a basic need for people. And yet, when we look at health work, one of the things we do is we task shift, which just the name itself is very symbolic of what we do. We give you a task. You can give injections, but heaven forfend that you should ever know what the injections are for, or you should ever be able to tell me that I've told you something wrong, or you should ever bring an idea to me about that. So this is about enabling people through good supervision, through mentoring, and through giving them feedback. And you all talked about that. Who gets the data on maternal mortality and morbidity? Who gets it? I bet it's not the health workers. And yet, they're the ones who can make a difference if they had that feedback, as well as the feedback about themselves. So we've been involved in India in a mentoring project where some very skilled nurses have been trained to be mentors in health workers in Karnataka? Yes. And what we found was that not only have the midwives become much better, or nurse midwives, they are actually much better at giving care, but they've also shown initiative. So I was reading a report on it. So, for example, broken radiant warmers have been repaired. You know, nothing really to do with what they're doing, but they've seen that they're broken and they've found a way to repair them. And that's taking the initiative. That's using your autonomy to do something that brings value to the job you're doing. So autonomy is number 1. Number 2 is mastery. So I took this from the report. Midwives can provide 87% of the needed essential care for women and newborns if educated and regulated to international standards. People want mastery. It turns you on to be really good at something, doesn't it? You know, it's exciting if you're really good at something. Leave it to me, I'll do it. I don't say that very often, I have to say, but my husband says this a lot. Leave it to me, I'll do it. So growth, stretch goals, and paying attention to how employees feel about what they're doing. And this can mean that, for example, in the wonderful example from Bangladesh, the folks that become those skilled birth attendants with the narrow training, I think you were saying, to me anyway, that there's a career ladder. So, build in a place they can go to show their mastery, to show how good they are, and exactly what you did, give them feedback loops. So somebody's saying to them, gee, that's really good, I remember when I was practicing clinician, I remember somebody told me that they didn't feel an injection that I gave them, and I was so thrilled. I was such a junior, and I was just like, I couldn't believe I'd done something so wonderful. But we don't encourage community feedback to these folks, and it can be so important in motivation. And then finally, and we shouldn't really have to say this in a health-focused meeting, but purpose, connecting yourself to a cause that's bigger than you are. And again, there have been some fine examples about, the midwives who are connected to communities and get feedback from the communities. That's their motivation. It's a purpose that's bigger than themselves. And again, it's about giving them the data. Give them the data. And you've talked about collecting qualitative data. I would say trying to collect data that shows that the quality of care makes a difference is so important and something we seldom do. So that's a quick, big idea on the road to better HRH. I hope that's done a bit of justice to the wonderful things you've been sharing. Thank you.
Thank you. So perhaps I'll hold on clarifying questions for Barbara because we can just open this up for further discussion. I know that we don't have as much time as we traditionally do or tend to when it comes to discussions. But if folks do want to ask any of the speakers in particular any questions, please feel free to raise your hand and specify if there's someone in particular or if the questions to the whole panel. So I see two questions and my colleague in the back, whoever you're closer to at this point. Sounds good to us. And we'll collect them both, and if there are more, and then give the panel a chance to answer at once.
Right. Thank you very much for a very enlightening series of talks. It was a huge interest and, in many ways, very enlightening to hear what other places in South Asia are doing. My name is Umrana Pasha. I am from the Aga Khan University in Karachi, Pakistan. And my question is to Dr. or Ms. Stillwell. I'm sorry. One of the real challenges that we are facing in Pakistan is malpractice amongst healthcare providers. And a lot of that malpractice is driven by financial incentives, that the provider is driven to do what is financially rewarding for them as opposed to what the patient really needs. And even in cities like Karachi, where more than 90% of women living in urban slums are now delivering in healthcare facilities or are being delivered by a so-called skilled birth delivery provider, we still see rates of neonatal and maternal mortality equivalent to rural areas. So there's really, in a rural area where there is 50% skilled birth attendants, and in an urban slum where there is 90% skilled birth attendants, there is no difference in the outcomes. And it has been my experience, and a lot of the data that we have collected shows that it is not a lack of knowledge, but a lack of aligning of incentives. If your financial incentive and the patient's outcome is not aligned, then you will do what serves your financial incentive and not the patient's outcome. So do you have any thoughts about that? I'd be particularly interested to hear.
Okay. And I think we had one more in the back, and other hands too, if folks want, we'll collect them once.
Thank you. I'm Lucy Mize. I'm the head of the health team in the Asia Bureau for USAID. And there are lots of things I'd like to comment on, but I know you don't have much time. So I just wanted to ask you, what can we do to promote your idea about the need to disaggregate data to look at the equity issues? You had listed a number of different factors. You need to look at data by tribe, by culture, by rural, urban. But I'm wondering what we can do to promote this concept, because equity is a really big issue, and you get fooled all the time by national numbers. Oh, wow, what a wonderful number. And then you begin to disaggregate, and it's like, what, excuse me, you've got how many hundreds of people dying in that region? So whatever you might think of as your next steps that the community could take up to promote that would be nice to hear.
Okay, great. So unless there's another question, maybe what we can do is go down the line. Anybody who perhaps wants to comment on the promotion of data to address equity issues, and then we'll conclude with you, Barbara, and then you can address the question around corruption. But I'm going to throw one more question in the mix as we go down the line. I'm hoping for those who were in Kathmandu, if you could say, you know, I know one of the things that we did when we were there was like, what's the key recommendations coming from each group? But now I'm going to ask you all, what was the key noteworthy, what did you take from it that you hadn't really, what's the key thing that you took away from the consultation that you hadn't really considered before? What influenced your thought the most by being in the room with the folks that Balvi and Oxfam and Anjali had spent so much time bringing together? So I realized my question, I didn't give you much time to think about it, but you want to start us off, Linda? Now I'm looking at Linda.
So the key things, first
Key
of all, is
thing
what
you
want us to
took
talk
away, yeah, what was the most innovative thing that came out of the consultation for you? And then if you had any comments on data and a promotion of it to address equity issues.
So having focused the past week on respectful maternity care, what was done in the meeting, and on data needs, I'm more familiar with those now than I am with the other groups at the moment. I guess respectful maternity care is clearly something very important, but maybe, in my opinion, it wasn't, to me, something that has not been addressed, because it has been getting a lot of attention, and it only takes one experience when you're in a labor and a delivery room and a doctor or a nurse or a cleaner or whoever says a sharp word to a woman in labor that makes you very aware of it. So while extremely important, maybe is not new, and it shouldn't be new. People talking a lot about what you just brought up, it's Lucy, right? Of disaggregating data so that it's available to be looked at and identified disparities, but also then available for communities to look at how are they doing compared to other people in their country, was something I hadn't thought about in a lot of depth before, despite having worked in data measurement for maternal mortality for quite a while now. So that I thought was very interesting, and it was driven by the people, local people who are working in country primarily, is a real gap that they're seeing that could be addressed. And also the need for routine qualitative data. I mean, to my knowledge, nobody collects that routinely on a national level, just in special studies. And yet it's such a rich source of information. All of the studies that I do now are mixed methods. They're quantitative and include qualitative, because we just don't feel we can do without it. As far as how to motivate disaggregating data, honestly, I don't know if I have a lot of ideas off the top of my head, but one thing that is without doubt very powerful is what your funders want. So USAID is in a very strong position to tell the countries that you support, we want disaggregated data. We want to know where the gaps are and where the strengths are, so we can help you plan. And that is definitely something that I would suggest. And happy if any other group has other suggestions.
Can I go next? Yeah, of course, just down the line.
So for me, what was the takeaways from the Kathmandu consultation. One, being in the position of the organizer, most enthusiastic for me was the enthusiasm of everyone that came together and how useful they found it. When we set out to do it, we knew it would be useful, but we didn't know that it would be so much appreciated, which also shows us that probably we do meet each other in consultations and conferences, but a platform like that wherein you come together and focus on a particular issue for, say, 2 days and in a smaller group is also that much important. In larger conferences, you lose out on some of that. Apart from that, one is what Linda mentioned about the importance of respectful care and how across the region this is an issue. While you know that women's situation is not very different in South Asia, but to hear it from participants who are there, who've been working in different capacities as clinicians, as public health experts, as midwives, everyone having the same view that respectful maternity care, reproductive health care is just not there. So that was like a cross-cutting thing for me and a huge reminder that so much more needs to be done with respect to women's rights. It's also a women's rights issue along with that. And the importance of midwives. In India, we've been talking of task shifting in that sense, that more capabilities, more skills be added to people who are working at the community level, but we also have strong lobbies from the Indian Medical Association and such other bodies who are against some of this because we understand the conflict of interest. But there was a talk of bachelor's in rural medicine and surgery, a BRMS course, a 3-year course wherein you take people from residing in rural areas, they undergo a training and then they go back and serve in their areas. But that did not come through because there was such a strong opposition to that by the powerful lobbies. So this is also some very political issues and political decisions which need to be taken and not the easy ones. But again, the focus on midwives, that how much more the midwives can do and should be doing. And in India, we're still struggling. In India, nurse midwives do not more than making beds and giving the injections that they're asked to do. So that kind of capacity building, empowerment of that cadre, which would take care of so much more. So here you have doctors who are super specialists and themselves would not work in rural areas. And when you want to build a cadre that would work, they would not let them also work. So I will not go, I will not let you go. So what happens to the poor? So that kind of dilemma. So to know that, and also what was heartening to know was that in places initiatives have been taken and have been successful. So for us, we can also do that in India. Regarding the disaggregated data you were asking, one is of course what Linda said. In Oxfam India, at least what we do is we mostly work with the marginalized communities. So the scheduled castes and scheduled tribes are traditionally the marginalized communities in India, and the religious minorities. So when we work with them, we collect, as we are working in that area, we collect data specific to those communities. And then when we compare it with the national data, which is across the board for everyone, you realize the disparity. So that is what we are able to do at the organizational level. But that is not enough, I think. We need to do it at the national level and have separate data. And according to that, we need to build our programs. About malpractices, Pakistan and India are not very different, I think. And we have this cadre of community health workers called the Accredited Social Health Activists, ASHAs, who've been brought out by trained, part of the government system, similar to what Bangladesh, what Jahangir presented, but slightly different because they are part of the government system. So that cadre has worked to a certain extent. There are certain limitations. And the focus on institutional deliveries, you said that urban also institutional delivery is happening, rural 50% institutional delivery, and still the outcomes are the same. So that is what we've been saying in India, that institutional deliveries are not enough. You increase the rate of institutional deliveries. Now, in India, it's anywhere between 80%, up to 80%, especially after the National Health Mission, cash incentives and all of that. But that doesn't mean they get quality of care. So institutional delivery is not equal to safe delivery, which is what we've been advocating with our governments. You need to see what a safe delivery is. So, thanks.
Yeah. Now, basically, just my take-home experience is more the way the quality of care was seen. It's a more respectful care. It's not from the clinical perspective. It's more social aspect of quality of care. So that was a huge discussion, and that's really just we find it's important. And another issue is kind of maternal morbidity. So the whole maternal morbidity issue even was not just recognized, and as because it goes again the way we see the woman and their position and in the society. So that reflect the, as because so many women, they are living with long-term disability, but nobody, and we are not counting it. And I think we started counting death, but we need to count morbidity. So that's a strong thing that we think that we took. And then about this disaggregated data, like if we, like as a practitioner, we see it's very difficult, like government want to show always this positive thing, okay, just we are serving these many people, these many women, but then how many poor and how many rich and middle class, that's sometimes very, and it's not really coming across. And then, and also sometimes there is a report that's from the provider's part, okay, the provider defined who is poor and who is rich, and so that's also not sometimes reflecting the reality. So that's why just maybe there are two suggestions from my part. Like one is, I think that most of the country, like including Bangladesh, we started some kind of counting the death of maternal death. And then if there is a kind of, we know the number of death and we know that their socio-economical condition, immediately we have some information like how many from the different quintile. And I think that still the NGO and civil society organization need to take this this role of this helping government collecting this disaggregated data. If it is not national-wise, almost some of the pocket and remote geographical area, and make it available to the government, so that sometimes if they see it and they really they try to act on it. But sometimes, so that's why I see that initially it will take time to institutionalize it. So that's why we see interim, there is a more active and collective role from the civil society organization, and the different donors. And that's sometimes a challenge. All the donors, they need to come together and work together for the cause. And regarding this malpractice, I really echo that it's a common issue, and always driven by the money and what they are going to it. And that's why the whole issue of this, if there is a kind of community feedback mechanism, which is called like there is a space, so that community and the poor family, they should get some space to communicate their experience. And that need to be created and to challenge us, because it's a more common voice and involving local government. And we are trying in Bangladesh, it's called community support system, so that they are kind of act as a kind of common voice of the community. And we did it in rural area, and for urban area we started to repackaging it. So that's something, that's the like immediate response to develop a kind of mechanism of feedback and challenge, at least to take, and then that will come just some point of time. And then otherwise nobody is asking this provider like this, they're reporting this 90% facility delivery, then outcome is same. So that kind of information should be there, and that feedback mechanism should be there. Thank you.
Thank you. I agree with you absolutely on this, the business of feedback, I think, and the incentives. I never thought I'd say this really, because it was never really my, I'm British, I never really believed in a market for anything. It was especially not health. It was a, socialist concept. So I never really believed that, anything to do with paying people to do things would have an effect. And of course, how naive was I? Because of course it did, and now they do that in England as well. However, they do one other thing, which I think is extremely important. It's called naming and shaming. And, it's tough, but I think if hospitals have very poor results, there's a list in the newspapers, and you can look where your hospital is, and you can go and ask them. You can say, look, if I have cancer in Birmingham, I'm half as likely to make a good recovery as if I have cancer in London. Why? And this has become a hot potato, really. So I think there's something about, allowing people to give feedback so the community actually can say, you know what, doctor, this is unacceptable. I notice that people are dying here in this hospital, women are dying. Why is that when they're not dying there? You know, I mean, and it's difficult because there's an imbalance of power. But unless you start it, it'll never change. So I think there's that. I think incentives are far more complex than people give them credit for. They think it's a linear relationship. You pay money, you get this. Not necessarily, unless you're talking about cauliflowers or strawberries. You know, you pay money to people, and people have all kinds of motivations, altruistic and otherwise, you know, for taking that money. So I think you've got to be pretty sophisticated in setting up incentive systems. But I do think involving professional associations in looking at incentive structures and having censure for people who abuse them is very, very critical. And I also think it's very important in low-income settings to look at the level of income you need to make a living and to build incentives above that, because sometimes incentives just make up the salary to a level at which it's a subsistence salary, and that's not an incentive. So then you start getting all, you know, the nurses say, well, what about me, and what about this? So it's a very, very complex system, I think, setting up incentives. But looking at supply and demand, you know, looking at how the association, professional association view it, and how community, and particularly, this is sometimes where media can be your friend, you know. You can actually get them, particularly the right type of media, to look at some of these issues and highlight them. And, you know, even doctors, begging your pardon, Linda, even Jangir, like mastery, you know. They do, they really do. They like to look good. And why not? We all do. So working on that, I think, can be very, very important. And I think also for, you know, disaggregation of data, again, who's using that data? Who's using those data? And who should be? And it's only when you disaggregate it, you can see the power for some people in areas that don't normally use data, the power of that data. And I hope you're not going to ask me to choose one thing. Thank you.
I won't do that. I do just want to thank you all for staying. I know we ran a little over, and I want to encourage you to continue to have such conversations. You can take a look at our website. Like I said, we've done a number of sessions on some of the topics that came up today, including one on maternal health and universal health care. And you can follow us on Facebook, Twitter, and via our blog. And I also wanted to just ask you to join me in thanking our speakers today.
Thank you, guys. Very honored to be in your company.
But I'm going to take a look at